This is Pat Iyer with Legal Nurse Podcast. Today, I'd like you to meet Kimmara Jackson, who is an OB nurse. She's highly experienced in high-risk pregnancy and teaching new nurses in the hospital. And we know how important that is with making sure those nurses get off to a good start. She runs a nurse career coaching firm, and she is a legal nurse consultant, and she writes a blog called The Pandemic Nurse. She founded KP Jackson Consulting, and she's located in New Mexico. Kimmara, welcome to the show.
Thank you, Pat. Thank you for having me on today.
I know that our listeners know from being involved in this field that OB cases are high risk for a variety of factors. And the topic that we're going to be discussing in this podcast is on some of the conditions that can occur before delivery, and specifically on some of the issues that can occur in an inpatient antepartum unit or a women's special care unit. Can you bring us up to date on what are some of the types of patients who are being hospitalized on those units now?
Okay. So some of the types of patients that we see on antepartum or women's special care are pregnant women. Their pregnancies are considered high risk for various things. Some of the population may be chemical dependent, so they're getting started on Subutex or methadone, or some of the women have preeclampsia, high blood pressure in pregnancy. And those women, once they reach a certain point and we do certain blood tests and we determine whether or not they're what we call pre-E, which is preeclampsia with severe features where there's some kidney involvement, or pre-E without features, which is showing that they don't have any kidney involvement at that time. I'll focus on a lot of the women who come in that have the pre-E with severe features. So those are the women that usually wind up on magnesium sulfate, which is an infusion that we give to relax the muscles in the body. So it's a muscle relaxant that we're giving them. Those women are not allowed out of bed. So they have a Foley in, and they use a bedpan for like bowel movements and other things like that. Sometimes women are on it for 24 hours. Sometimes they're on it for a few days. Sometimes they're often on it. Just kind of depends if we're able to get them weaned off of the magnesium and onto an oral medication like labetalol. But a lot of times we can't get them weaned, or if we can get them weaned, they're still not stable enough to be sent back out into the community and to go home. Those women are at high risk once they're on that magnesium. That means that their blood pressure and their kidney function, they're placed at risk, high risk for having seizures. So they're also on the seizure precautions as well, with the padded side rails and not being allowed out of bed. We're also checking reflexes, because if they're becoming what we call magnesium mag. So if they're becoming mag toxic, one of the first things to go in most cases are the reflexes, or she becomes really lethargic and she's really sleepy. And some patients notice that they're becoming sleepier and some don't. So that's why we're doing vital signs every hour, making sure their blood pressure is not getting too low or not getting too high if we're weaning them down. And also to make sure that we're not depressing respirations by her becoming so lethargic and so relaxed that she's not breathing enough.
Well, let me take you back. Let's unpack that a little bit. You talked about women who have kidney involvement. How does preeclampsia affect kidney function?
Okay, so it decreases kidney function. A lot of times it decreases the perfusion to the kidneys. So some moms are at risk for like an acute renal failure.
Mm.
Over my 20 years in nursing, I haven't seen a mom go in for dialysis because of it, but some of my colleagues have had moms that had to go and receive some type of dialysis. And that's also why we have the catheter in too, so we can keep a really close eye on that urine output, because even though there might be a little bit of kidney involvement, we can really see before the lab tests start to show anything if her kidney function is really dropping off, because her urine output will decrease or the quality of the urine will change. She'll go from having, light yellow urine to having like a dark, like tea colored urine sometimes before that kidney function drops off
Hmm.
as well. Because we keep those moms really hydrated. In addition to giving them the magnesium, they're also getting either normal saline or lactated ringers.
So I'm thinking about this from the perspective of the mother who's walked into the hospital and now is in bed with padded side rails and a Foley and is being watched almost constantly. Do you ever encounter people who get rebellious over that type of care or are not compliant?
Yes, so I've had moms rip out their IVs and say that they're leaving, that they're ready to go. I've had moms sneak out of bed, climb over the side rails, because just because they have the padded side rails, they still can move their arms and their legs, and they should. We promote that, just not climbing over the side rails. So some will climb over the side rails, and you'll walk in the room and catch them coming out of the bathroom, and you're like, okay, so policy is you have to be in bed. And on the antepartum unit versus sometimes when they go over to labor and delivery allows them to walk magnesium going. But once they leave labor and delivery and go down to postpartum, they're back in bed again, just like they would be on the antepartum unit. So, yeah, there are instances where moms are not compliant. For the most part, moms are compliant because they know that this could be detrimental not only to themselves, but also to the unborn child they're carrying. But on occasion, you have moms that are like, I'm sick of this, I'm done, I'm out. And I've actually had moms leave AMA as well. And that's a time when you're stalling that mom until that provider gets there. And usually the doctors are running up to the unit to try to educate further, as well as if she ultimately decides to leave, which it ultimately is her right, that we're covering all of our bases as well, that she was equipped with the information and she knew the risks versus the benefits of leaving and staying in the hospital. And she signs paperwork and then she's allowed to go.
That is such a touchy issue when people want to sign out AMA. And although they have the right to do it, the risks are often very high when a person does that. But I also remember, Tamara, when I was in labor with my second child, I remember looking over at the obstetrician who was sitting next to me in the labor room. And I said to him, that's it. I've had enough. I'm done. I don't want any more contractions. I want to go home. I'll tell you what, you switch places with me. You have this baby and let me leave. And he said, of course, I'll do that for you, Pat. And I thought, yeah, right, right. It takes a lot to push a person to just want to give up. And I could see how women who are on seizure precautions in bed, having their blood pressure taken every hour, 24 hours a day, I could see why they would want to throw in the towel and just be done with it.
Yeah, and some of the women that I care for at the hospital I work at, some of those women have other children at home and their support system and resources are very limited. It may be a situation where she starts out and she has help with the other children at home, but then the person that agreed or persons that agreed to help her have other obligations that may have come up. So sometimes it's a social thing too, why they want to leave as well.
And you have to empathize with that. What mom wants to be laying in the hospital knowing there's nobody there with their kids?
Yes,
That's an almost impossible situation.
Mhm.
Going back away from the social situation, which we can't solve on this podcast, the
No.
thing that you also brought up is the importance of looking for changes in vital signs, changes in blood pressure. Tell our listener a little bit about the critical thinking that goes into that level of monitoring, and how much experience do you have to have before you can detect those changes? Or is that something that's so obvious that anyone, including new graduates, would know and recognize if the patient was changing?
Okay. So blood pressure, vital signs, new grads are really good about that. They're sticklers about the vital signs. And I think that's because that point had been driven home with them in nursing school. But those other signs like lethargy or a reduction or absence of deep tendon reflexes, those types of things are a little more difficult for the new grad to handle, or for them not necessarily to handle, that's not the word I want to use, but for them to pick up on, because those things aren't the things that are driven home in nursing school. It takes a little bit of clinical judgment and honing that clinical judgment to be able to tell when a patient is lethargic. They're also, as new grads, they're focused on a lot of the listening to the patient and stethoscope, auscultating, those things like that. They oftentimes, forget that patients' mental status or their alertness, that Glasgow Coma scale, they forget that as well. And that's something that is monitored on antepartum, as well as labor and delivery, postpartum, as well as that Glasgow Coma scale. That's something that we use as a tool that is objective for us to be able to see that this patient's mental status or their alertness is declining. But it takes a while for a nurse to be able to pick up on those subtle changes. Sometimes when you're doing deep tendon reflexes, you're not always, using the bell of your stethoscope to tap in the right spot. So you're not eliciting that jerk there. Or they may not be doing it, hard enough because they're afraid they're going to hurt the patient by really kind of doing the motion and eliciting that jerk in that mom's legs. So it takes a little bit of time to notice those more subtle changes. Sometimes they walk in and the mom is asleep, so they don't necessarily notice her being an increase in sleepiness. They don't notice that right off the bat, whereas someone with more experience can determine, is this person difficult to arouse and how difficult they are to arouse.
Mm-hmm. And one of the things that has been coming out in my podcast lately is a concern with how you build in that critical thinking among new grads. I was talking to one of my nursing colleagues last night who commented that the new graduates coming out of school now have less clinical time, particularly the ones who were finishing their programs in 2020 and 2021. And another one of my podcast guests, Jennifer Gunther, talked about the nurses being pushed through their orientation faster once they get a job in the hospital, so that they can be that extra pair of hands, or maybe not even extra pair of hands. What are you seeing in your clinical area? You're working with high-risk patients with preeclampsia regarding the new graduates' ability to function in that setting. Are they getting enough support?
So I'll say yes and no. So on the yes side, there's always someone that's more senior on a shift where that nurse has additional resources. There's usually either a formal charge nurse or a relief charge nurse on the shift, as well as some of the more senior nurses. So there's someone for them to ask. However, on the flip side of that, oftentimes I've seen nurses being taken off of orientation early to take an assignment that maybe their preceptor said, she's really good at just a basic antepartum patient, no mag, none of that type of stuff, just basic, maybe hyperemesis or something like that. So her orientation or his orientation could be either shortened or they're pulled off for a shift to take an assignment, because oftentimes units are short. And units are often short, not just because of call-ins or anything like that. It can be caused by having COVID patients on the floor. Most hospitals, a COVID patient is a one-to-one patient. It's not the COVID patients that we all see, on the news that are in the ICUs and intubated. It's just because that mom, she's functioning, she's awake, she's breathing on her own, she's eating, drinking, all of that good stuff, but she has COVID or she's tested positive for COVID. She may be asymptomatic, but they're all treated just the same. So the nurse that's on orientation may get pulled off, not to care for the mom that's tested positive for COVID, but because the unit is now short staffed, because we may have 4 COVID patients on the floor, which means there are now 2 nurses that are taken off of regular assignments where they can receive, 6 patients to just take the 2 COVID patients apiece. So there are times where those nurses are pulled off of orientation. And a lot of times I've seen new nurses not be comfortable. Sometimes they're literally like scared to move because they're like, I was supposed to be on orientation another 3 weeks, but now I'm being pulled off to take this new assignment and I've never been on my own before. So that's also a thing. And then because everybody's so busy and running all over the place, they become kind of nervous about asking for help because they don't want to be perceived as a burden, or they don't want to be in the way, or because they'll tell me, I've had nurses tell me, they thought of me enough to be able to give me this assignment, even though it's a lighter assignment, it's not as difficult as the rest of you guys' assignments, but I don't want to look like I don't know what I'm doing. So some people, I've seen new grads do the fake it till you make it. And, on any inpatient floor, whether it be antepartum or med surg, fake it till you make it is not a good thing to do. It's not a good motto to live by in nursing, because you can run into trouble. And the new grads also a lot of them don't know about like safe harbor and those types of laws and legislations that they can call upon when they receive an assignment that they don't feel ready to take. Maybe they took care of a patient that was hyperemesis, but this patient has a Zofran pump. They may not have received that training yet. So there are things that they can utilize, but oftentimes some of those things are not highly advertised to them. So they're not aware that those things exist to safeguard themselves as well as the patient.
I know when I was in charge of hospital nursing orientation back in the early 80s, safe harbor didn't exist. The whole concept of protesting an assignment was something that we knew about, but we didn't instruct new graduates. And now I think I should have, about what do you do if somebody assigns you something that you think is more than you can handle. I found new graduates to be bundling quivers of nerves, excited, overwhelmed, and all the factors that you discussed, Kimmara. They don't want to admit that they don't know something, or that they're putting too much demand on their coworkers. And yet when something goes wrong, we both know as legal nurse consultants, they are judged by what a reasonably prudent nurse would have done in that same situation. Is that the reasonably prudent new graduate with 2 months of experience, or is that the standard that you should understand the standards of care regardless of how much experience you have? And I know that that plays into your analysis as a legal nurse consultant when you're looking at a case, determining what should have been done. Can you comment at all about the standards of care and how the healthcare team communicate those standards of care to each other?
Okay. So the standards of care are communicated oftentimes through the orientation period, as well as a lot of the units I've worked on have resource sheets or job aids as well. Sometimes they go missing, they grow legs, they go home in people's backpacks and things like that. But we try as hard as we can to give the new grads and as well as the more experienced nurses, because sometimes there are things that the more experienced nurse may not encounter as much on the unit, especially some of the nurses that may not be working full time. They may be working PRN or per diem, or they may be re-entering the workforce after a time of being out of work for whatever reason, whether it was for illness or to take care of children or family members, those types of things. So the standards of care are communicated verbally as well. So we all are kind of our brothers and sisters keepers on the unit. When we notice that someone even looks stressed and they have a high acuity assignment or even a lower acuity assignment, but the patient may be exhibiting some signs that they may be moving more towards the higher acuity, we're constantly asking, what is it that you need? Or we're saying to them, oftentimes when somebody's starting a patient on magnesium, they'll come out and they'll say, I have to start room such and such on mag tonight. So we're all like, what do you need? Do you need me to start a Foley? Do you need me to start an IV? Have the doctors come down and talk to her yet? You know, those types of things. So we're also cueing each other in to those standards of care as well.
Yeah.
So if something is going to be missed, like they got the order for the mag, but the provider hasn't come down and actually had a face-to-face formal conversation with the woman, we're like, okay, before we go in there trying to stick a Foley and stick an IV in this mom, we need them to come down and talk to her about the risks, the benefits, what she's going to expect. You know, all of these things that a doctor should discuss with the patient and answer her questions, and make sure you're in the room for that so you know what was discussed, because oftentimes they're in a whirlwind of events happening, and you can remind them what those standards of care are. You can remind her, you know, she's not supposed to be out of bed. You know, you can remind her, you know, that we've got to put the IV in. We have to put a catheter in you, those types of things. You can remind her. And also, we have patient care techs on the floor as well. And a lot of the patient care techs have been on the floors longer than some of the nurses have. So they know the standards of care. They know to monitor urine output, and they're going in when they're doing vital signs once an hour. They're going in and they're emptying that Foley. But I always encourage nurses, make sure you check your Foley. You go in there, you know, you check your Foley. If it looks like urine output is decreasing, check the chart and make sure the tech hasn't emptied the Foley before you contact the provider.
Mm-hmm.
And if it's not charted, communicate. A lot of hospitals use these little phones that only work in the hospital, and so we can easily send each other. Different facilities call the messaging different things. One of the facilities I work in, we use Tiger Connect, so we'll Tiger message each other, you know, those types of things. So we can always keep in contact with one another when patients are going on like magnesium or their vital signs are changing significantly. we're always notifying the charge nurse. So the charge nurse is aware so that when he or she goes to make the next shift assignment, that assignment is appropriate based on the acuities that are on the floor as well. And the charge nurses are also a huge resource in knowing the standards of care, knowing the policies and procedures, as well as knowing the new standards that are coming out, and they distribute those to all of us via email, as well as reminding people when you're notifying the charge nurse of a patient that may be moving to a higher acuity.
It sounds like a wonderful system of reminders and backup where you're working together as a team, particularly to help the new graduate who is in a situation where all of those details are so important.
Yes, those details are very important. When all else, fails, sometimes there are things that we don't always encounter, like antepartum, postpartum. Primarily, we don't do active voiding trials. So to know how to do that on the unit, there may be no one on the unit that has done one at all, or it's been a year or two since they've done one. So referring to Lippincott is a huge resource, so that standard of care is right there, and that most hospitals have access to that. So looking up like Lippincott procedures and looking up how to do an active voiding trial or how to start someone on magnesium, those are also resources that are available as well to all nurses. And that is a high standard with Lippincott, as well as the hospital policies and procedures as well.
And for our listener, can you describe your LNC practice? In other words, do you work behind the scenes? Do you do expert witness work? What types of services do you offer attorneys or legal nurse consultants?
I work primarily behind the scenes. So I'm doing things such as reviewing the medical record, creating a chronology, creating a fact summary report. I also organize the record and can do exhibits and create exhibits for attorneys and for other legal nurse consultants as well. I also do some subcontracting work. So anytime a legal nurse doesn't feel like that OB case is not something that he or she can handle, I'm always available as a subcontractor as well. So I do a lot of the behind the scenes work, and that's just scratching the surface of what all I do. But I also find expert witnesses. I don't do expert witness work, but I do find expert witnesses and vet them so that attorneys have a little pool to choose from for their witness.
How can our listener find out more about your services or get in touch with you?
Okay. So you can get in touch with me in two places. The one website is my career coaching and blog, The Pandemic Nurse, at thepandemicnurse.com. And for legal nurse consulting services, you can reach me at kpjacksonconsulting.com.
All right. And that's letter K, letter P?
Yes.
jacksonconsulting.com. Kimmara, thank you for your expertise. I'm sure our listener has gotten a sense just by this last half an hour that this is a highly nuanced and complex area of OB care, where things like kidney function and brain function and seizures are all tied together in a very delicate balance.
Yes, it is. Yes, it is. And to make sure that the ultimate goal is to keep mom safe and to have a safe delivery. Our goal is to get these moms to term as much as possible.
I can see why that's so important. Thank you for being my guest, and thank you to you who's been listening to this. Be sure to go to podcast.legalnursebusiness.com, sign up for the transcripts for our show, And also look at our latest bundles. We have put together the most popular shows based on the number of downloads and assemble them into categories so that you can dive deeply into a particular aspect of legal nurse consulting with those bundles. Thanks so much, and be sure to click on down for the next show. This is Pat Iyer, and I just finished a podcast with Jason Tracy on some of the concepts related to sales. And you may be thinking, well, I'm a legal nurse consultant. I'm not a salesperson. Jason, let's talk about what we covered in the podcast. First of all, to answer that question, what are some of the highlights of what we discussed in your show?
Well, we answered that question for one, and why sales is so important to your business and to the longevity of you staying in business. We recapped and we talked about taking more control and more action, and not waiting out there and not knowing if somebody's going to call you or not. You can take that next step action. We talked about the importance of telling a story to both your clients so they understand what your value is in the marketplace. And then most importantly, telling that story and understanding your story for yourself, because the most important person to sell before you sell anybody is you. You are going to be your first biggest sale. Belief is everything. Believe in yourself and back up by how have you served and how have you helped people in the marketplace in the past.
Thank you, Jason. Great recap. Be sure to catch Jason Tracy's podcast. You'll be wanting to listen to that with a pen in your hand to write down those writer-downer tips as Jason describes them, so that as you think about sales and how it relates to you in closing sales and bringing work in, you can apply some of Jason's principles. We'll see you at Jason Tracy's podcast.